Welcome back to Decode Healthcare with Harshal. Now, if you were with us for part 10, we successfully conquered the pelvis and the hip. Today, for part 11 of our Explainer series, we're moving straight down the leg to tackle the biggest bone in the body, the femur, along with the knee joints.
All right, so here's our roadmap for today. We'll start with a quick welcome to the femur, go over the golden rule of open versus scope, dive into total knee replacement codes, look at femur fractures and IM nails, touch on coding thigh amputations, and finally, wrap things up and look ahead to our next episode.
Okay, Section 1. Welcome to the femur.
So we're jumping into the 27301 to 27599 code range today. But, before we even look at a single procedure code, let's just get our bearings. The femur is that massive bone spanning your thigh. It basically serves as the heavy-duty bridge connecting your pelvis directly down to your knee.
And honestly, the sheer scale of what we're dealing with here is pretty incredible. Simply put, the femur is the longest, heaviest, and absolutely the strongest bone in the entire human body. Why does this matter to us? Well, understanding this massive size and strength is totally vital for medical coders because it dictates the intense, high-impact types of procedures required to fix it. You definitely don't just slap a simple splint on a crushed femur, right?
Moving right along to Section 2, the golden rule, open versus scope.
All right, before we assign a single code in this section, we absolutely must establish the golden rule of knee coding. This is a crucial, zero-fluff guideline that you literally cannot afford to forget. This specific section of your CPT codebook is almost entirely for open surgeries. So what does that mean in practice? Well, if the surgeon makes a big cut with a scalpel to physically open up and expose the joint to the naked eye, boom, it's an open surgery and it's coded right here. But, and this is a big but, if they only poke a few tiny holes to slip in a little camera to fix something, say a meniscus, that's an arthroscopy. And arthroscopies belong all the way at the very end of the book in the 29800 series.
Just take a look at this setup. Notice the arthroscope, that tiny camera, entering the knee joint through just a tiny little incision. If your operative report describes a scenario like this, you've got to stop exactly what you're doing and flip your book to the 29800 series immediately. Seriously, do not code a scope in the open section. Just don't do it.
All right, Section 3, total knee replacement codes.
So, keeping in mind that we're strictly looking at open procedures today, let's dive into the repair, revision, and reconstruction section. We're going to focus heavily on one of the most common open surgeries you'll see, arthroplasty. You probably know it better as a total knee replacement. So why do doctors actually do this? Well, typically it's performed when severe bone-on-bone arthritis has completely worn away the natural, smooth cartilage of the knee joint. The patient is usually in terrible pain, their joint function is just shot, and that smooth surface needs to be entirely rebuilt from scratch.
Now, to accurately code this, you really need to visualize what's actually happening in the operating room. Picture this. First, the surgeon shaves off the worn-out arthritic ends of the femur and the tibia. Then, they cap both of those freshly shaved bone ends with these smooth, artificial metal components. And finally, they glide a high-density plastic spacer right in between them. That plastic spacer is so cool because it acts just like healthy cartilage, allowing those brand-new metal pieces to bend and glide perfectly. And there you have it. That's your total knee replacement.
Let's keep going. Section 4, femur fractures and IM nails.
So, cast your mind back to our anatomy lesson from a few minutes ago. The femur is incredibly strong. Breaking the thick shaft of this bone usually requires massive, high-impact trauma. We're talking something like a severe car crash. When a patient suffers that kind of intense trauma, the absolute gold standard for fixing a mid-shaft break is intramedullary or IM nailing, which you can see doing an amazing job of securing the bone here. To put it simply for our coding purposes, an IM nail procedure literally means the surgeon is hammering a long, incredibly strong titanium rod right down the hollow center, the medullary canal of the bone. Once it's in there, they secure it with screws at the top and the bottom. This holds that heavy femur perfectly straight while it heals. So whenever you see IM nail pop up in an operative report, just know this is the exact heavy-duty mechanical engineering happening inside the patient's leg. It's pretty wild stuff.
Moving down the page, Section 5, coding thigh amputations.
Okay, the absolutely crucial takeaway for this section is that your specific CPT code changes depending on exactly how and where the cut is made. For instance, if the amputation slices straight through the thigh bone itself, which is known as a transfemoral amputation, you're going to be looking at code 27590.
But if the surgeon doesn't actually cut through the bone and instead separates the leg entirely at the knee joint, well, that's a complete disarticulation at the knee, taking you down to code 27598. As always in coding, you know the drill. Location and technique are everything.
And finally, Section 6. Wrap up and next episode.
And just like that, we've wrapped up our clear, zero-fluff tour through the open procedures of the femur and knee joint. We've conquered the anatomy, hammered home that golden rule of scoping, and broken down total joint replacements, heavy-duty fracture care, and amputations. Make sure to hit that subscribe button to Decode Healthcare so you don't miss our next explainer. We're going to travel even further down the skeleton to conquer the lower leg, the tibia and fibula, and the ankle joint, covering codes 27600 all the way to 27899. Now think about this. If the massive femur requires heavy titanium rods, what kind of complex hardware do you think surgeons use to rebuild the delicate weight-bearing joints of your ankle? Get your codebooks ready because the rules are about to get even tighter. Catch you next time.